It's important to learn a little bit about the morphology of all the different blood cells. Interestingly, as a physician, you're going to order a lot of complete blood counts, but rarely will you actually be the one that's looking through the microscope. Nevertheless, when these reports come and hit your desk, this way you'll at least know what you're looking at when you look at that CBC report, and you'll understand the terminology and phraseology of each of the terms on that complete blood count, as well as if you ask for a peripheral smear. Welcome to this presentation on morphology of blood cells. In this presentation, we will take a look at a variety of the blood cell types that you can see on a peripheral smear. And the interesting thing is just how much information you can get from looking at these blood cells. I want to thank Dr. Yen Kuo for giving me a template from which this presentation was created, and also give credit to Dr. Roshan from the University of Ottawa for helping with part of the template for this presentation. Also, don't forget there's a 16-question quiz at the end, and most importantly, there are some photographs of blood cell morphology at the end here in the quiz that I won't necessarily go through in the presentation. So make sure you do the quiz and make sure that you can recognize each of these different cell types. So for references, I've used several textbooks, none of which are specifically on your required book list. The one that was the easiest to actually read turns out that it's this one here, the Color Atlas of Hematology by the Tima people. It's available through the LRC. And the second easiest book, which kind of walks you through everything, is this one here called Hematology, Clinical Principles and Applications. You don't have to buy either one, but you'll notice some of the images I've taken are from the Color Atlas of Hematology. So if you actually want to go to the LRC and find this textbook, it may help you. So there is some required reading. It's this guy here. It's called The Diagnosis from a Blood Smear. So in order to download this article, take the presentation out of presenter mode from the PowerPoint that I'll give you, and then double click on the icon and it should open up the paper for you to read. So let's take a look at some of the learning objectives for this presentation. First and foremost, we need to recognize what a normal red blood cell looks like. Then we're going to look at some reticulocytes, and then we're going to look at some red cells which are deformed, and that's known as poikilocytosis. We're going to look at some sickle cells, some schistocytes, spherocytes, and target cells. And then there's going to be a little bit of an introduction to hematopoiesis. Now, you're going to get hematopoiesis, which is a fancy word which means how the blood cells are formed from the different sites that blood cells are formed in, i.e. the bone marrow, the spleen, the thymus, etc. You're going to get a lecture on that later from other professors. So erythroblast will be covered in other lectures, but I do want you to look at what a hypochromasia red cell looks like, the importance of microcytosis, macrocytosis, and anisocytosis. Perhaps the most important two are macrocytosis and microcytosis. These are actually given to you on every CBC that you order by looking at the MCV, the mean cellular volume. So if you want to take a note, the mean cellular volume is the only clinically useful red cell indice on a peripheral smear and on a CBC report. So we're also going to look at some platelets and megakaryocytes. As you know, megakaryocytes are the initial cell from which a platelet is formed. Here we see a picture of red cells and then all these tiny platelets around it. In addition, we're going to look at white cells, which are granulocytes. And the reason they're called granulocytes is they have little granules in them. So we're going to look at some neutrophils, which are called polymorphonuclear leukocytes, which neutrophils are basically the ones that help you with infection. Then we'll look at some eosinophils, which are most present in people who have allergic reactions, and even in some odd diseases like eosinophilic esophagitis. You might want to look that one up just so you can put two and two together. Then we're going to look at some basophils, and then we're going to look at, very briefly, some immature granulocytes. Most important will be the band cells. Now, the myeloblasts, the promyelocytes, and the myelocytes will actually be covered in other professors' lectures on hematopoiesis. But for this presentation, the band cells, which are the immature neutrophils, are going to be the most important thing to look at. So here's a picture of a neutrophil. And then we're going to take it down and look at some agranulocytes. And as you can imagine, these are white cells that don't have granules: lymphocytes, plasma cells, monocytes, and macrophages. And so once we've gone through all of this, you'll get a better idea of what you're looking at under a microscope. So from the required reading, I also have some questions that I want you to be able to answer. What stain is most commonly used in a peripheral blood smear? What's an automated blood count? What's a manual blood count? And when would you request either one? List indications for obtaining a peripheral blood smear. Notice that a peripheral blood smear is different than a complete blood count. I want you to define macrocytic anemia, define a microcytic anemia, define thrombocytopenia, and then tell me what role iron, folic acid, and vitamin B12 play in the diseases of macrocytic and microcytic anemia, and which one of these anemias is most often seen in alcoholics, and why is that, and think in the back of your head how you would treat that. Then, and I've already answered this one for you, what red cell index is the single most clinically significant index, and why? The answer is the mean cellular volume, the MCV. And the reason is because it helps you to determine whether your patient has a macrocytic anemia or a microcytic anemia. And then recognize on the peripheral smear hypochromasia. In other words, someone who might be iron deficient, their red cells are not as bright red under the microscope. Tell me what Howell-Jolly bodies are when they're seen, what basophilic stippling is of a red cell, and what diagnostic use that is. Let's talk about sickle cell features, what spherocytosis is, microspherocytes, what a left shift is on a complete blood count, what a blister cell is or a bite cell, and then what is a target cell. What are all these signs of? And then what are other signs of hyposplenism? And what is peripheral eosinophilia indicative of? And what is basophilia indicative of? What peripheral smear features are seen in G6PD deficiency? Again, this is going to come from your assigned reading. And name a disease that erythrophagocytosis is seen in. And this one, just go look this up. Go type in on Google erythrophagocytosis and find a disease that this is seen in. What is pernicious anemia? How does it appear on a peripheral smear? What's the importance of fibrin strands in a patient with platelet satellitism on a peripheral smear? And what's the significance of a blast cell on a peripheral smear? So, no, I am not a hematologist. I'm a surgeon, but we are looking at probably 10 to 50 CBCs every day, and after a while, they expect you to know what you're looking at. So what's interesting is you're going to need some image banks to go to, and you can click on any of these links on the PowerPoint that will take you to some sites that have really nice images of CBCs. And the one that I prefer is the University of Utah site because I think that it has the best images. Also, the TEMA ebook, which I've already mentioned, is also very good, and you're going to see that I've used some images in it. So over here on the right-hand side, this is what we talk about when we talk about poikilocytosis of red cells. You go from a normal red cell to a small red cell to a big red cell to one that looks oval to one that doesn't stain as red, to premature types, to a sickle cell that you might see in someone who has sickle cell anemia. Here is a schistocyte from someone whose red blood cells are being ripped up and torn apart by perhaps a mechanical heart valve. And then we see basophilic stippling, rouleau formation. We won't specifically get into this, but these are different things that you should recognize, and you will, of course, see these not only in your exam, but you'll see these mentioned on all of the CBCs that you order in your career. So we know that red blood cells, white blood cells, etc., are all part of the peripheral blood that we draw in a test tube. Normal blood is made up of plasma, contains water, proteins, nutrients, and then of course the hematocrit, which is the percentage of the blood that is actually made up of red cells. And then there's a buffy coat, which appears between the plasma layer and the hematocrit. And the buffy coat is where the white blood cells and the platelets sit. So someone who has anemia, of course, doesn't have enough red cells, and someone who has polycythemia has too many red cells. And these people can actually clot prematurely, and this is a problem. And believe it or not, polycythemia is one of those diseases where we actually treat you by having you come in and pretend we're vampires and we drain off some of your blood. Red cells are also known as erythrocytes. White cells are leukocytes. And the number of neutrophils is actually greater than the number of lymphocytes, which is greater than the number of monocytes, which is greater than the number of eosinophils and basophils. Not so important that you know this, but it's just a fact of a peripheral smear. Normal white cells are divided into polymorphonuclear leukocytes, PMNs or granulocytes because they have little granules in them, and mononuclear cells that have one nucleus and might be agranulocytic. And how do we know which ones are which? Well, we stain them. We can either use an acidic stain or we can use an alkali stain when we look at these under the microscope. So alkaline stain usually will stain blue, and acidic stain will stain different components red. So you're going to get lectures on hematopoiesis. Basically, this is just a slide that says you get all these different all these different blood cell types from a pluripotent stem cell, or depending on how you pronounce it, pluripotent. These stem cells, which mostly are in the bone marrow, but they can be in other portions of the body too, give rise to all the different cells that we see. Megakaryocytes will give rise to platelets. A erythrocyte under the chemical direction of colony forming growth factor will give us an erythrocyte. We have basophils, monocytes. Lymphocytes will come from a specific stem cell in the lymphoid stem cell. And of course, a neutrophil is our white cells. And of course, the red cells come, the eosinophils come from the same colony forming unit as does eosinophil under eosinophilic growth factor. But not so important that you know all of this. Again, here we just are showing the same thing. We're showing how somebody has figured out that there's these omnipotent stem cells, and then we have these pluripotent lymphatic stem cells and other myeloid stem cells, where eventually we end up with plasma cells. Plasma cells will secrete antibodies. Plasma cells are direct descendants of B lymphocytes, and the only way you can tell a T lymphocyte from a B lymphocyte is through special staining. And then, of course, there's these natural killer cells, and all of these can just be determined by different stains, but under the light microscope, many of these are going to look the same. What we're going to focus on for this presentation is these guys right here. We're going to look at basophils, some eosinophils, monocytes, macrophages, neutrophils, thrombocytes, and erythrocytes. All of this other stuff, the birth of these cells, will be covered in other lectures on hematopoiesis. We're not going to do that here. So as a blood cell matures, basically what happens is it comes from these giant cells in the usually bone marrow, but they can be formed from the liver or the spleen. Before you're born, they can be formed from the thymus, which is where we get some T cells. But these giant cells end up reducing in volume. They get smaller in size as they mature, and the chromatin, which is all throughout the cell, initially will condense and form the nucleus. And then, of course, the cytoplasm becomes less basophilic. So the cytoplasm becomes less purple in color until eventually we're going to get an erythrocyte, which we know stains somewhat red or pink, depending on whether the patient's anemic or not. And then there are these white cells. Now, white cells are considered granulocytes because they have little granules in them. And these granules, of course, can secrete various chemicals. but there are basically three types of granulocytes. There's a neutrophil, there's a neutrophil, an eosinophil, and a basophil. Neutrophil, a basophil, and an eosinophil. You're going to see eosinophils in people who have allergic reactions, basophils, and the same thing. And these two are very similar. We're going to learn that they secrete heparin and histamine, which you guys know what histamine is. And a neutrophil, of course, is a white cell. And then we're going to go into the mononuclear cells, which basically have a nucleus which is made up of one shape. So here we have a lymphocyte. We're going to see later how a lymphocyte gives us T and B lymphocytes and then plasma cells that secrete antibodies. And a monocyte, a larger cell with sort of a kidney-shaped nucleus. So we're going to look at all of these and be able to recognize all of these and how they look under the microscope. So let's keep going. Make sure that you can recognize each of these as we move through. And like this image here will tell you really kind of what you're looking for. So neutrophil has a bilobe nucleus. Eosinophil has a bilobed nucleus with red cytoplasmic granules. I'm sorry, the neutrophil has multilobe nucleus, multilobe. So let's just keep going and see what we can find out. So reticulocytes. So reticulocytes are basically premature or immature red blood cells that don't have a nucleus, that have a reticulated appearance when they're stained. So here we can see these reticulated appearance. It's a premature red cell, and basically this is a sign that the body is releasing red cells too early. Now, why would the body release red cells too early? Well, it's someone is bleeding or has chronic bleeding or chronic anemia and they can't make red cells quick enough. The body releases these premature red cells called reticulocytes, and you can see them in the peripheral smear when they're stained, for example, with the various stains. So here it's showing the ribosomal RNA, which is basically what this reticular stuff is. It's a ribosomal RNA, which is part of a nucleus, and as a red cell matures, it loses its nucleus, and so what we're seeing here is a premature red cell. So normal red cell, you know what they look like. They look like little flying saucers. They're biconcave disc. They really have little or no mRNA as they mature. And they, on average, live about 120 days before they're cleaned out by the spleen in an adult. And I give a lecture on the spleen a little bit later. And we go through what all the spleen does. But let's take a picture. Let's take a look at this photo over here. Here is some of the various types of cells that we're going to learn about. So we know the red cells, these guys right here. These are normal looking red cells. They look pretty good. The reason you see that little glow here in the middle is because the center of the disc is reflecting back at us. But that becomes important in someone who has anemia, who may not have enough iron, and then you're going to see that reflective surface almost completely envelop the entire red cell. We have a lymphocyte, we have monocytes, we have basophils. Notice the granules here. We have a neutrophil, which is a white blood cell. We have eosinophils with all these little granules that are getting ready to release histamine for our allergic reaction. And then a band cell is basically a premature neutrophil. So before these guys are born out into the circulation, they present as a band. Same thing, whereas a reticulocyte is a premature red cell, these bands are basically premature neutrophils. So somebody that comes in and has a lot of bands, that means they're sick, they're pouring out white cells, and the white cells are hitting the periphery prematurely. And so someone who comes in and has lots of bands usually means that they're pretty sick. And we'll see more of that later. So what's the clinical significance here of red cells that have this, they're out in the peripheral circulation, they have this what's called basophilic stippling. It's not related to a basophil, it's related to the color of the stain, a basic stain. So nucleated red cells containing basophilic stippling suggests that someone might have either a megaloblastic anemia or even lead poisoning. and the dots are condensed ribosomes or RNA here. So basophilic stippling here in a peripheral smear, all these red cells. And you might be wondering, oh my God, how can I tell the difference between this and an erythrocyte or a basophil or a macrophage? By the end of the presentation, you'll have a better idea. Howell Jolly bodies. So up here, Howell Jolly bodies. These guys right here signify a damaged or absent spleen. The spleen normally removes diseased or old red blood cells. These are red cells that are diseased, and the spleen hasn't removed them. But the difference here between the stippling, where you have multiple little condensates of the RNA or the ribosomes, to just a couple, is what will help you determine whether you're looking at basophilic stippling or an absent spleen. Someone who might have lead poisoning or someone who's lost their spleen. So poikilocytosis is abnormal red cell morphology. Red cells can take all kinds of crazy shapes under the microscope. Spherocytosis and some of the diseases that you can see this in. Elliptocytosis, schistocytosis from a heart valve crunching away and killing and ripping up the red cells, all the way down to a target cell, which we can see in iron deficiency, and here a stomacyte in alcoholism. We're not going to go through all of these, but we're going to show you the most important ones. So here, let's look. We can see red cells. They look pretty good. We see little tiny platelets in this, but red cells will show usually only a slight variation in their size and shape, and these are all normal looking. And remember, the little reflection here is the UFO shape, the little disc shape of the red cell reflecting the light back at us. So when you're looking at a blood smear, you should examine these in an area where they're not really touching one another. And you'll notice that in most of the red cells, this reflective area will take up about a third of the size of the red cell. But if it reflects more than that, you could have hypochromasia, meaning it doesn't stain darkly enough because there's not enough iron within the person's body, and they could have iron deficiency anemia. So there's our picture of our red cell, that little UFO saucer-shaped presentation, and here in the middle of it is a platelet. So now let's look at these red cells and how they're formed. So we've already spoken about reticulocytes, how they're precursors to the initial erythrocyte, but the reticulocytes themselves come from the erythroblast. And here we're looking at, over here we're looking at what these various cells will look like. So here is an erythroblast, and eventually out here in the peripheral circulation, we can see that mostly this patient's got normal looking red cells. They look pretty good. But erythroblast give rise to a normoblast, and then these will stain either multiple colors or with one color where they're only able to no longer divide. So I don't like to read my slides, but I got to read this one to you. So the results of mitosis of an erythroblast is called a normoblast. And then the immature cells in the cytoplasm display a grayish blue hue, which are still able to divide, and those are called polychromatic erythroblast. While the cells are in the cytoplasm is already taking on a pink hue, which means it's got a lot of hemoglobin, and then they're no longer able to divide. So now we get these orthochromatic erythroblast. The nuclei of the later gradually condense into small black spheres without structural definition, and they're eventually expelled from the cells. So they kick out their nuclei, spit them out, and then we get these enucleated young erythrocytes. And if they're too young, they're going to come out and you're going to see that little bit of reticulocyte in them where you can see that little tiny condensed spot of RNA. So why do we care? Well, if we look at a peripheral smear and we see somebody has too many reticulocytes, Of course, like I said, that usually means they're bleeding. They have an extramedullary production of blood. The marrow can't keep up with their requirements. Or you might be looking at a bone marrow that has cancer in it. So whenever we see too much erythrocytes, whenever we see too much reticulocytes, we're looking at the body trying to compensate for hemorrhage or iron or vitamin deficiency. So that's the clinical importance of a reticulocyte and the fact that they come from erythroblast. So let's take a minute here and talk about white cells now. So without going deep into the creation of all the white cells, basically we know that white cells are either agranulocytic, meaning they have no granules. So these guys down here have little granules in them. Those are called granulocytes. No surprise there. Neutrophil, eosinophil, basophil. Just gave you those earlier. Or they turn into lymphocytes or monocytes, which are agranulocytic. So let's take a look at these guys. So here we can see neutrophils. These are basically an early white cell that is a granulocytic cell. There are many neutrophils in the circulating blood, and they're mainly mature segmented neutrophils. So if we look at the nucleus of a neutrophil, you can see that the nucleus has many segments right here, many segments, whereas a premature neutrophil doesn't yet have that, and we call these band cells or premature white cells. And again, bands, they're also called stabs. Just like you're going to stab somebody, you might hear that term. A band or a stab means someone needs white cells and they need them quickly, and the body's pouring out these premature white cells, which normally are not seen. They're also called PMNs, polymorphonuclear neutrophils, and they're good for about 12 hours in the circulation unless they get to a site where there's pus. Then they collect and they die, and along with dead tissue, and they last for about 2 or 3 days in the dead tissue where they form as pus. So in this image, what we're looking for here are the band cell, which is these guys here, where the nucleus hasn't yet turned into the multilobular segmented neutrophil. So this is why they're called segmented neutrophils. So this one, these are some variations of the segmented neutrophils, but here again, bands and early segmentation, later segmentation, band. And so if we look at this under electron microscope, we can see that they have a lot of these little granules in them. So here's the nuclei, which are segmented. So this is a PMN. And these neutrophils can go out and eat and digest bacteria, cellular debris where they collect in the tissues. They're good for 2 or 3 days as pus. And they actually can do this via diapedesis. So by being able to sort of, so pedicis means feet. So by using I'm going to screw this up, diapedus, they're can grow these little tiny extensions here, sort of like pseudopods, pseudo legs, I guess. Not quite like an amoeba, but maybe a little bit like it. And in response to chemotactic gradients, they can call out these PMNs and go over and start chomping away and eating bacteria and other infectious sources. And of course, we know that they're released from the marrow or other sites in response to perhaps like a bacterial infection, and then we see that as an elevated white count on the peripheral smear. So diapedus is important. Means that the cell can actually sort of crawl along the wall of the blood vessel until it reaches the site of the infection and start chomping away. We call this a left shift if we look at a peripheral smear and note that there are a lot of immature bands. And I mentioned this earlier. If I'm looking at a peripheral smear and the lab tells me that there's a lot of neutrophils, and they break it down for me into segs and bands, they'll give me, for example, let's say 75% segs, 25% bands. If someone has 60% bands, they're really sick. They're pouring out white cells, and I need to keep that in the back of my head when I treat them, because that means that they're going to be really sick. So a band neutrophil is a premature form of the segmented neutrophil, and too many of them is referred on your complete blood count as a left shift. So let's take a look at an eosinophil. I mentioned earlier that these guys are often seen in allergic reactions, parasitic infections, cancer, etc. So here's a nice picture of an eosinophil. It's granulated, lots of little granules. They're saying that it stains an orange or a red color. And if you go over here, if we look at these guys here, I guess if you use your imagination, you can see a lot of granules here in this cytoplasm. So here you have a bilobe nucleus. That's sort of bilobed. I'm not sure that I'm smart enough to tell you that that's not a segmented neutrophil, but this one's definitely bilobe. This one's bilobe with lots of granules. They say they stain orange or red. And if we look at the caption here to the picture, it says eosinophilic and basophilic granulocytes. The eosinophilic granulocytes with orange stained granules. Okay, use your imagination. In contrast, the granules of a neutrophil are not round, but are more bud-shaped. I'll be honest, I can't tell round or bud-shaped. I don't know what they're talking about here. The nice thing is that as a surgeon, I would never have to look at a peripheral smear and tell you any of this. Here in F, very prominent large granules. Yeah, you can see those. Those are some pretty big granules. In a basophilic granulocyte, in someone who has chronic myeloproliferative disease. So this guy here with these big giant granules in that large cell, that's not normal. This one's normal, that one's not normal. Bilobe nucleus, red granules, eosinophil, seen in allergic reactions. So if you have really bad allergies or you're allergic to something and you come in and I draw your blood, we're probably going to see what's called eosinophilia. So these eosinophils are highly phagocytic for antigen-antibody complexes, and they can even chomp away and eat other neutrophils. They are attracted to sites of inflammation by substances released from basophils and a mast cell. And we're going to look at a mast cell here at the next slide. The presence of eosinophils, I've already said, suggests an allergic response to a specific antigen. Maybe that antigen for you is a food product, or maybe it's pollen, or maybe it's peanuts. And then a mast cell is a connective tissue analog of a basophil. So we're going to first show you what a mast cell looks like, and then we're going to talk about a basophil. So let's look at these guys here again. Bilobe nucleus, lots of granules. I don't think they look orange. They look purple to me, but they say they're orange or red, bilobed here. And here on this one, we see eosinophil. So bilobe, multiple granules, lots of red cells out here, a few platelets. There's a platelet with a lymphocyte underneath it. So that's what we're looking at in these pictures. So here's a mast cell. A mast cell is similar to a basophil. We're going to show you that in the next slide. And that the mast cell and the basophil both contain heparin and histamine. And remember, histamine can be blocked by drugs like Benadryl, which is a H1 receptor, or H2 receptors, drugs like Tagamet or Zantac for peptic ulcer disease. Histamine is released in the presence of IgE, and we know that IgE, interestingly, it happens to correspond with the word eosinophil. So IgE, which is an allergy-mediated immunoglobulin. So here's our mast cell. Here's our resting mast cell, and then after he's gone over and done some karate and kung fu, he's activated. He's shed a lot of his granules, and here we can see a lot of these mast cells under high magnification. Again, they have lots of granules, granules here on this electron photomicrograph. Here's the single nucleus. These guys are full of heparin and histamine. The basophils leave the marrow mature, so they leave mature, whereas the mast cells mature in the tissue site. So next slide, which is the basophil, they leave mature. These guys have to go out and get activated. So these mast cells need to get activated, and interleukin-3 does that. So here's our basophil. Again, these are granulated white cells, remember. So here, a basophil has deep blue or violet granules. So I'll buy that here. These are our deep blue or violet. And they tell us here that these are basophilic granulocytes. The granules are corpuscular, like those of an eosinophil, but they stain deep blue to violet. Again, to me, they all look the same color on these pictures. In F, we see a very prominent large granules, and again, this one's abnormal. Okay, this guy's abnormal, too big. The granules are too big, and the nucleus looks kind of funky here. So we will see basophils, which are increased in a myeloproliferative disorder like this guy here, parasitic infections, or allergies. So here's a three-dimensional view of a basophil, single nucleus here, multiple granules, lots of granules here. And remember that the basophil leaves mature, whereas the mast cell has to get a little interleukin-3 for differentiation and growth before the mast cell can become activated and go do its karate out in the peripheral circulation. So the basophils are the least common leukocytes. Now, I thought this was interesting. Basophils are infrequent in a normal peripheral blood smear, and their significance is uncertain, which explains why whenever I got a CBC that showed lots of basophils, I usually stared at it and had no idea what to do with it. So it turns out that I was wasting time staring at it and thinking about what to do with it because their significance really was not certain. So again, they're blue staining, which means that they're basophilic, they're alkali loving. They have histamine or heparin. We've beat that one to death. And they are the least common leukocytes, but they increase vascular permeability during an inflammation or an allergic response. Remember, they're dropping out histamine, and they're dropping out heparin to keep the blood from clotting. By the way, you might remember heparin was discovered by a medical student many years ago. Do you remember his name? I do, but I'm going to drive you crazy, so you have to go look that one up. So now let's look at some normal white cells. These are lymphocytes. Now, lymphocytes are agranulocytic. These are the smallest white cells. They have a large condensed nucleus with just a little bit of cytoplasm. So giant nucleus, little bit of cytoplasm. So here is a lymphocyte. And these will actually, through the process of hematopoiesis, turn into a T cell or a natural killer cell or a B cell. And then B cells can turn into plasma cells. And these plasma cells then secrete antibodies. But we see lots of lymphocytes if someone has a viral infection or chronic inflammation. So so here you are, a patient comes into the emergency room and you're looking at their CBC and you note that they have a huge lymphocytosis, which means either they've got leukemia or they most likely have a viral infection. Notice this is in distinction to the neutrophil count. So let's say someone comes in and they have 75% neutrophils with 10% 10% bands or stabs, and they've got 30% lymphocytes. So that means they probably have a viral infection if they have that lymphocytosis. So using the lymphocyte count in combination with the neutrophil count broken down into stabs and PMNs can help you determine if your patient has a acute bacterial infection or whether it's a viral infection. So here I've got to read a little bit to you. Sorry about this, but this is important. So lymphocytes are produced everywhere. These white cells are produced everywhere. Of course, we know about them in lymph nodes. Before you're born, produced in the spleen, the bone marrow, and sometimes in the intestine or even the thymus. And of the thymus will make T lymphocytes. About 80% of our T lymphocytes come from the thymus, whereas bone marrow spits out about 20% of B lymphocytes. And remember, it's those B lymphocytes that turn into plasma cells that secrete antibodies. So if we go down here, the important point is that small lymphocytes which cannot be identified as a T or B lymphocyte on the basis of morphology. They have to be stained, but they undergo transformation in response to specific immunological stimuli. The final stage of a B lymphocyte maturation is a plasma cell, and whose basophilic cytoplasm is layer is always wide. And so why do we care about all this? Because an elevated absolute lymphocyte count, often along with cell transformation, are observed predominantly in a viral infection or disease of the lymphatic system, i.e. like lymphoma or leukemia. And mature plasma cells, remember these are the guys that secrete antibodies, are found in blood and help us secrete antibodies, but a plasma cell-like lymphocytes occur in a viral infection also, and they can also be abnormally high in plasma cell leukemia. And I'll show you an example here of someone who has another disease which you've probably heard of, and we'll get to that here in just a second. So now let's look at a monocyte. Monocytes are the largest white cell. And remember, these are agranulocytes. They got a giant, sort of a bilobed, kidney-shaped nucleus. They've got a little more cytoplasm, which is sky blue. They're active in the circulation for 1 to 3 days. And then once they're in the tissue, they can differentiate into a macrophage and go have lunch on some bacteria with about an 80-day lifespan. So when will you see a lot of monocytes? Well, you've heard of the kissing disease. Someone has mononucleosis on a peripheral smear. Those patients will have an elevated monocyte count, which if they're in the peripheral smear, they're heading out to go chomp away at some macrophages, or in the case of mono, a viral infection, which is consistent, of course, with our high elevated lymphocyte count. So monocytes are produced in the bone marrow. Their line of development branches off very early stage from the granulocytic series, but does not contain any distinct specific precursors that can be securely identified with diagnostic significance in everyday morphological studies. Okay, what does this mean in English? So I'm looking at a peripheral smear. There's nothing on a monocyte that lets me look at it and say, wow, that is a monocyte 100%. There's nothing on it that makes it totally distinct. So why do we care? Well, we've already spoken about monocytosis in cases of infection, always present in the end of an acute infection or in chronic infections like endocarditis. You can also see it in Crohn's disease, ulcerative colitis. These are two diseases of the intestine, the colon, the small bowel. Crohn's disease can occur at the small bowel or the colon. Actually can occur anywhere in the GI system. Ulcerative colitis is only in the colon, but these are chronic diseases. So someone who has a chronic long-term disease, you're going to see this monocytosis. And now here's the other one. You can see monocytosis in some cancers, Hodgkin's disease. So you've got to be careful when you look at this and you get back a lot of monocytes. Does the patient have mononucleosis? Do they have Crohn's? Are they at the end of an acute infection? And how do we know for sure that these monocytes or specifically their precursors are being identified correctly? Keep that in the back of your head. Monocytes are hard to pin down from their precursor cells. So now we're just talking about plasma cell, because a plasma cell we know comes from a B cell, and these guys secrete antibodies. These are larger mature lymphocytes, and all the textbooks say they look like a clock face. I don't think they look like a clock face. To me, they look like a scale that you step on. But there is a disease called multiple myeloma, and these patients get these plasmacytomas on the skin. You cut these puppies off, you look at them under a microscope, and they are just loaded with plasma cells. So here's a plasma cell, right? Okay. These are the guys that secrete antibodies. And again, maybe this looks like a clock face. I guess it sort of has a nucleus with 3, 6, 9, 12 o'clock. But the mature plasma cell lymphocyte in the peripheral circulation looks like this guy. And here, I guess they're trying to say it looks like a clock face. Again, I think it looks more like a scale that you're stepping on. And then here is a patient who has multiple myeloma. And turns out that it causes bone to be eaten away. And you take an X-ray of the skull, and they have these areas in the skull which are literally eaten away by these crazy plasma cells. And I suspect, I've seen patients with multiple myeloma, but I've never seen a biopsy of the skull lesion. But I suspect these are probably also plasmacytomas. They're just in the skull. So this is the importance of a plasma cell. It's sort of an atypical lymphocyte. It looks like either a clock face or a scale that you'd stand on. They secrete antibodies. They have an eccentric nucleus and basophilic cytoplasm. And most importantly, they secrete antibodies, and they come from a B cell. And the only way you can tell them from a T cell is by special staining. So platelets, you know what platelets are. Platelets help you clot. They come from a megakaryocyte, which is the precursor cell in the bone marrow. Normal platelets are small anuclear fragments. They don't have a nucleus. So these are just little fragments floating around between your red cells that help you clot. They do have some purple staining granules. They're derived from a megakaryocyte, and they only last 8 to 10 days. Occasionally, we'll see what's called a platelet ribbon. And so here's some red cells. These all look normal, a nice little UFO-shaped disc. And then you see these platelet ribbons. This is when the platelet is being shed into a marrow sinus by the megakaryocyte. And the ribbon will then eventually break up into numerous smaller platelets. Probably not really clinically significant, other than if you see these, they're just a little precursor to the normal platelets getting ready to break up. So you look at a slide, you look at a peripheral smear, and you see these red cells here. They're reflecting way too much light. This person has hypochromasia. They probably have a microcytic anemia, indicative of their iron is probably low, or they're bleeding somewhere. But here, and that makes sense, because if they're bleeding somewhere, we're losing iron, and you're going to see these platelet aggregates. And they're composed of multiple intact platelets. They're degranulated. And the problem is you're going to come back, and the platelet count's going to be low, which makes sense in somebody perhaps who's bleeding, trying to stop the bleeding. Everything's aggregating. So it's essential to look at these peripheral smears to see if you have platelet aggregates, which is accounting for the reason that your platelet count is low. So even though this aggregate is made up of 50 platelets, the truth is the computer will only count this as one platelet. So a normal platelet here, normal platelet here, normal one right there, bunches of them here, and you'll get a spuriously low platelet count. So here's something else which is kind of cool. You get satellitism. This is a phenomenon where the platelets adhere to the outer wall of the white cell. So here we have a granulocyte, because it's got little granules in it. It has multiple nuclei. So this is a polymorphonuclear leukocyte, or a neutrophil. And we got all these little platelets that stick to it. This is only seen in vitro. It's only seen in the test tube. There's no clinical significance. However, it's important if it's detected, since the platelet count will be factitiously low. So again, the Coulter counter, which is what gives us our CBC results back, will tell us that the platelet count is low, and the truth is the platelets are all stuck to the white cells. So platelet satellitism. Occasionally you'll see skin cells mixed in. So here's a polymorphonuclear leukocyte. Here's a great big giant skin cell, an epithelial cell. And you'll often see these on blood that's drawn peripherally, meaning that we stabbed you in the antecubital vein to get this, as opposed to drawing blood from a catheter where the blood is coming straight out of the circulation. If it's coming straight out of the circulation, you won't get skin cells, but if I draw it peripherally, you will. So again, it's important when you look under the microscope that you can recognize these skin cells and not to confuse the normal skin cells with cancer cells, which can be occasionally seen floating around in blood. Again, I'm not good enough to do this with a microscope. Dr. Fish could do this easily, but I can't. So the epithelial cells are occasionally seen from venous blood samples, which I just mentioned. They have oval nuclei, a grooved surface. I think this is interesting. The nuclei have grooves in them. These little, I don't know what they are. They're probably some sort of ribosomal derivative, but they have grooves in them. Just don't confuse them with cancer cells. So now let's look at some artifacts. So here's a fixation artifact where there's a little water that got into our methanol. And what happens is we get these rings, these refractile rings. And once we see these rings, we go, oh, somebody was, pouring water and diluting my methanol, probably trying to go in the woods and make some wood grain alcohol and sell it to pay for their school loans. So, when I see this, all bets are off. I can't read anything. This is junk. This is trash. It's bad artifact. Here's some more artifact. Heating of a blood sample. For example, we're running across town. We got a blood sample. It's in a hot car. And then we can see these microspherocytes. These guys right here. Now, this peripheral smear is interesting. This got lots of stuff in it. So we have a crenated red cell, which is also called a Burr cell. This is from too much heat. We have microspherocytes, which sometimes the Coulter counter will confuse these and think that they're platelets. And then here, of course, we see a band or a stab. This is a left shift neutrophil. Same thing here. This has one nuclei, scant cytoplasm. I think this is probably a large lymphocyte. Maybe a plasma cell. Not sure. It's that cytoplasmic vacuole there that raises suspicions. So let's take a look at this. We've got normal red cells. We've got Burr cells. We've got spherocytes. We've got, here's another Burr cell, or what's called a crenated red cell. Another one here. All artifact. This is all artifact from too much heat. So what's the significance of this? Well, in somebody who has been exposed to fire, okay, remember we're talking about heat, we can often see this. So here's an example, and I've taken this from the New England Journal of Medicine, where a guy comes in, he was involved in a burn injury, severe burn injury, face, thorax, and upper limb, and his platelet count comes back at 85,000. A normal platelet count's about 125, 150,000. And what was happening is the spuriously normal platelet count obtained by means of an automated system was due to the misidentification of microspherocytes as platelets. So physicians should consider the possibility when dealing with patients with a burn. So the misidentification of a spherocyte as a platelet. So they're saying that this 85,000 is normal. I will tell you that that is low normal. Low normal. And so if it didn't count these spherocytes as platelets, your number would have been even lower, which is a bad thing. So here's what happens when we store red blood cells. Here we get these Burr cells or these crenated cells. Prolonged storage of blood before making the smear can cause to artifact. And here we can see what's called a smear cell. This is a white cell which has become very fragile, and it's lost some of its cytoplasm. The nucleus still looks okay, but the cytoplasm's all pulled out. And you know something's going on because you have these crenated red cells. So we got artifact here. Well, we probably can't use this at all. And then when we look at the this neutrophil here, we see that like I said, the nuclei has rounded up like in a ball, whereas they're saying that this, and I'm sorry I made a mistake earlier, this is a smear cell. This smear cell has fragile, and the nuclei is too big. Now, looking at this, could this be just a lymphocyte, a normal-looking lymphocyte with probably a premature seg here? It could be, but the giveaway is you have all these crenated red cells. So whatever's going on here, I don't trust it. So here we have white cells becoming fragile, creating a smear cell. Again, that's not something that I could tell you by looking under a microscope. And then down here, we have what they call roundup, nuclei roundup. And then you get lots of these Burr cells and crenated cells. So just artifact. That's the take-home message here. So let's take a look at this. Here we can test our knowledge, and I'll tell you that on the presentation for this, that the answers are found in the notes section. So this is a platelet. This guy here is a stab or a band. This is a polymorphonuclear leukocyte. This has got lots of granules. This is bilobe nucleus, lots of granules. This is probably a eosinophil. This, not totally sure. This looks like a mast cell to me. And this guy, some sort of, this is a lymphocyte for sure. Don't know. So I'm not good enough to look at all these either, because I don't have to look at these, but you guys do for your tests. So speaking of test, let's keep going, and let's take a look at some images here that you should be able to pick out. Now on this, a few of the cells I mentioned, but they're not shown in the presentation, so you got to go through this quiz and identify all these guys. So the answers, of course, are in the notes section on the PowerPoint, and the questions that I'm going to write for your test will come mostly like a point and identify. Tell me what kind of cell this is. Tell me what's in the granules. What would you see clinically? Is this a viral infection? Is this a bacterial infection? Stuff like that. So let's take a look here. The white cell shown here is blank, and I'll let you go look that up. So let me go through these. I'll shut up. I'll leave these play for 5 or 7 seconds, and then you write your answers down and go check it with the PowerPoint.